combination of mechanisms seems to be really, really important. There's a way in common parlance when people talk about stress or distress or anxiety, it comes across as if people like myself are saying that any adversity or any stress is bad. And I don't actually believe that. In fact, being a developmentalist at heart, I know that if there wasn't stress and distress, none of us would have learned to walk. None of us would have learned to feed ourselves, right? That's inherently how we develop, and it's okay. In fact, it's even good if it's in the right size and in the right context. Stress becomes toxic when it is overwhelming of the child's coping mechanisms and leading to long-term, and then it can lead to long-term impairment. And then the area that's really interesting, and I think people who are dismissive of folks saying that we have to protect children from stress and distress and abuse, and there are some, I meet them. The area of controversy is about the idea of tolerable stress. Because I bet if we think about our lives, we all can think about things that were really bad, but it went okay. We handled it okay. So stress can be positive, it can be growth promoting, it can be tolerable, or it can be toxic. And again, I think if you really sit back and think about that, that shouldn't be controversial. But how do you define the boundaries? And how do you just, if you were trying to take care of a child or take care of a school or a system, how do you decide what's over the top and what's not? It ends up being very challenging. But we have some things that are clearly in the toxic range. Things that happen over and over again, or of a severity that it would be disruptive to anyone. Witnessing your mother be assaulted, witnessing a murder, or unrelenting prolonged distress or fear. Those things clearly are toxic. The absence of adult support seems to be a really important predictive factor. After a bad event or an adverse event occurs, one of the best predictors of resiliency to the event is whether when you talk to the child, they believe that it's over, right? That if adults basically said, yes, this was horrible, but now it's over. Whereas if it's not really over, then you're still experiencing and you're still having the stress and response and sometimes toxic response. This slide just tries to put visually some of the ideas that I'm talking about. So many of us, if something happens, whether we classify it as clearly traumatic, whether you like that word or not, or just difficult, we have a reaction that can range from vigilance to alarm to fear to outright terror. And depending on the magnitude of the reaction, and individuals will vary about how big the reaction is to each event, we can have an initial response that is in fact adaptive, right? And some of the response I'm talking about is from adrenaline coming into your system, you have added strength and circulation in your muscles, and if you're trying to jump out of the way of a car or a lion, that's great. But if you're trying to sit in the classroom and put up with everything that's going on in your environment, that doesn't necessarily help you. And so, but we have these reactions, and then for most of us, for most situations, we have a calming effect. And for folks who are identified, unfortunately we identify them retrospectively, as resilient, they tend to have a quicker response. For folks who've experienced recurrent trauma, and for folks who do not have either historically or in the moment adequate adult supports, their reactions to similar events tend to be more significant physiologically and more prolonged. And that really does seem to be damaging and correlate with some of the bad outcomes that we're talking about. Then this can become a vicious cycle in families and in communities, where having your own experiences of trauma, of toxic stress, can actually impact your parenting capacity. And then if not the same events, but similar types of sort of shocks to the system, traumas happen to your child, and they have their own reaction. If you have a trauma history, that can impact your capacity to respond appropriately and provide the support to promote resiliency in a child. And so then we see PTSD running in families. We see reactions to traumas running in families. And the consequences of the traumas themselves, whether it's addiction or just being engaged in impulsive, unsafe behaviors or post-traumatic stress disorder, can also put their kids at risk for future traumas. And I mentioned epigenetic changes. That's been a really interesting literature, but it does seem that having a trauma history turns on genes that we then see in multiple generations. And things that we strongly suspect but haven't found the aha mechanism, if you will, like bipolar disorder, to have a genetic cause. If you have a first-degree family member with bipolar disorder and a trauma history as a child, you are way more likely to have classic type 1 bipolar disorder. I'm not, for those who are well-informed or even cynical about it, I'm not talking about mood swings that someone calls bipolar disorder. I'm talking about classic type 1 bipolar disorder is more likely to actually develop in adults who have a first-degree relative with a trauma history compared to not having the trauma history. Yeah?
What's the SUD and the IPV?
Oh, I'm sorry, yeah, the alphabet soup can be confusing, right? IPV is intimate partner violence or domestic violence. SUD is substance use disorders. That's the current DSM term for addictions or chemical dependency. If you see other things that I've abbreviated or you don't understand, don't hesitate to ask. This is one of the slides that someone else put together. The cultural normalization of violence can make this hard to sort out sometimes too. Again, this idea of this sort of vicious cycle of trauma happening and inadequate responses that people don't even remark on, right? If your community is so used to violence, then behaving violently when you're upset or distressed isn't seen as weird or a problem in some circles. And when you talk to people in the moment, it can actually be a somewhat effective, and I use that term carefully and judiciously, somewhat effective in the moment coping response. People who feel threatened and react aggressively, if you talk to them about what happened when they were feeling threatened, they talk about it, and to the extent we have physiologic data, they seem to have a diminished response. By reacting aggressively, it seems to get them through the moment. Right? It doesn't help in the long run, but it kind of gets through the moment. And we certainly see with community violence increased rates of PTSD and what we call externalizing problems. So that would be aggression, that would be blaming others, as opposed to internalizing problems like anxiety and depression. And post-traumatic stress disorder symptoms are reliably in a community predicted by not only being a victim, but witnessing or even hearing about community violence if it involves people that you know or that your family knows. How many of you are familiar with this picture? So this is so about a quarter of you raise your hand. So this is the Crescent area. This is a term that was coined by former Mayor Bill Johnson as the city of Rochester. Right? And he took a visual of poverty levels, decline in housing value, and violent crimes, superimposed these images, and came up with these high density areas, which they coined the term the Crescent. Now, I use the term in these two slides. It's not actually, for those of you who live in the city, you know that's not really the name of a neighborhood. And for the folks who live here, many of them don't like the name the Crescent. It kind of has a negative connotation. But for identifying where these problems are happening, it can be a useful descriptor. Interestingly, even though it wasn't part of the data when this was the term was first coined, this is also pretty predictable mapping of where you'll find houses with high levels of lead in the paint. In Rochester, in this Crescent area, the estimates are that by the time a kid's 15, they've either in some way witnessed or heard about 500 homicides and about 3,000 violent events or crimes. That's just overwhelming numbers, right? And yet that seems to be true. Now again, some of that is hearing stories, some of that is watching the news, but they're in the neighborhoods, they're living it. And if you look at folks that are involved in juvenile justice, 12 to 17-year-olds, folks who go through our system in Monroe County that are identified as coming from these neighborhoods, 95% have clinically significant behavior or psychiatric issues related to violence and related to, trauma histories by the time they're in care. I work in the Monroe County Children's Detention Center, and that's where the sickest kids I see are, behaviorally, psychiatrically. And it is, again, it is really a trauma problem. Now I'm going to transition a little bit and give some more data about ACEs in our local picture, and also those previous, I mentioned that some of the slides were created by others, those previous slides with a different background were from Tim. Most of the rest of the slides are going to be from CCSI in Monroe County, who've done a lot of work on ACEs, and in the last few years have used the Youth Risk Behavior Survey as sort of a mechanism to get at this, and not only about frequency of problems, but also what we can do about it. How many of you are already familiar with the Youth Risk Behavior Survey? Okay, so not everyone. This is an interesting thing that it's available and administered nationally. Not every district participates. There's been a big push in Monroe County to try to get every district to participate. And they ask a lot of questions. As the name implies, a lot of it's about risk behaviors and behavioral and emotional and health status questions. And regional areas administering it can add their own questions, and Monroe County does. So I'm going to talk about some of the results from the YRBS around ACEs. First thing is just frequency. This is from the 2017 data. In Monroe County, we administer it every 2 years. And in 2017, we see about, similar to the number I showed you earlier nationally, about a third do not endorse any ACEs at all. About 25%, 1, and then about a third, 2 or more. And just to be clear, we talk about some of these things worsening over time. The numbers from 2015 were pretty much the same. So the rates of reporting of these types of adverse experiences doesn't seem to be increasing. For me to say that, a lot of my day-to-day life is looking at the tremendous increase in people presenting for mental health care. We've had a 30% increase in the number of kids coming to our Psych ED in the last 5 years. So that's interesting, and that may reflect some positive things, like people seeking help. But the actual reports from kids from the surveys have not changed that much in the last 2 years or in the last 4 years. We do see, I'm not going to, these slides can be posted, as Bill mentioned. I'm not going to go over every detail, but this is some of the gender spread. You can see it's not for males and females, it's not that different, but if people identify as a non-cisgender, they tend to report more history of adverse childhood experiences. This type of survey doesn't help sort out what happened because they identified as gender nonconforming versus what happened before, but this is what the survey shows. In terms of academic impact, this is probably not surprising if you think about it or try to make a guess. People with less ACEs have better grades by their self-report. And if we look at race again, the people of color tend to have more ACEs. However, it's not zero for anyone, right? I mean, this really does cross socioeconomic status and crosses race and gender and other ways of breaking down people. It's a human phenomenon, but we do see some significant differences.
What's the age range of the respondent?
So this would be high school students. It's a great question. When it's administered, they try to get a representative sample, and then do some things to, if they get a better turnout in, say in Penfield and Pittsford, when they do the analysis, they try to population match it so that the data we report in these slides is representative. So if you get like 100%, it's not 100%, but if you got 100% response in Penfield and a 30% response in Rochester, then they adjust it based on population so that these visual slides of the percentages are intended to be representative of high school students. There are something, and actually I think that the data managing, the figure managing around population size is solid and sound. For the parts I care about most, the biggest problem with relying on YRBS is it only catches people who are at school that day. Right? And so for the folks that I see and that I'm most worried about, actually everyone who's in a psychiatric hospital, everyone who's in residential, any teen who's in a substance use treatment program, they're not captured in this. This is only the people that showed up for school that day. So you know, it's for the folks who aren't there, we'd be guessing, but we can guess it's probably worse. Some of the other important things that come from this, about 64%, or about 2/3 of students with 4 or more ACEs report feeling sad for 2 or more weeks in the past year. Now, if that seems arbitrary, why they pick 2 or more weeks, that's one of the criteria to diagnose major depressive disorder. So that's why they picked that. And about 60% report with 4 or more report just generally difficulties with emotional problems. And I'm sorry if it's not large enough for you to be able to read the next few slides are going to be similar. This would be, it's not intuitive because 0 is on this side, and then 1, 2, 3, and 4 or more ACEs. Same thing, we go 1, 2, 3, 4 in the columns and then 0. So now looking at violence. 39% of students with 4 or more report carrying a weapon to school in the last 30 days. That's impressive to me. You know, if I think about the youth I work with in the emergency room and the detention center, it rings true. The implication of this volume of weapon carrying is kind of staggering when I think about it across schools. But again, it does seem to ring true with my clinical experience at least. 50% report engaging in a fight in the past year. Now you don't see it in this summary because we're lumping all Monroe County together, but you do see variations in districts about fighting and talking about fighting, where we see more in the city school district, but not exclusively. And 39% of students with 4 or more ACEs report being a victim of violence within the past 30 days. So to some extent, if you think about how surveys work, people are going to be more likely to report things that happened recently, so that might not be a surprise. But I think that this is indicative of the fact that, again, it's 4 or more, so it's not their first victimization. Having a history of adverse childhood experiences is a risk factor for being a victim of violence. And it has a cumulative increasing effect. Now, substance use. I realize that this is the graph is probably hard to read because it's so small, but essentially it's similar trends with what I'm saying already. The more ACEs you have, the more likely you are to endorse using substances. And if I wanted to reduce this to the 3 important take-home points about the effects, this is what they would be. Compared to youth with 0 to 1 ACE, youth with 2 or more are 9 times more likely to have attempted suicide, are 5 times more likely to feel sad for 2 weeks or more within the previous 12 months, and are 4 times more likely to have endorsed on the survey having come to school under the influence of substances. So again, these are really significant risk factors. But what can we do about it? And this is actually to me, I find the implications for understanding how trauma impacts us medically and psychologically across the lifespan fascinating. But to some extent, it's only an intellectual exercise unless we can do something about it, right? And I know that we are all here, and the reason I was invited here was to really talk about this. And there are things we can do about it. And there is a growing science of evidence-based programs to mediate and modulate the effect of ACEs. Now, the stuff I'm going to talk about, if we can prevent violence, parental death, abuse, that's even better. The stuff I'm going to talk about, though, doesn't address that. But for people who are experiencing these factors, what makes the difference to promote resiliency? And some of the things that I list here, in case you can't read them, there's a program that actually was largely developed and studied here, the Family Nurse Partnership. There's other similar programs, but Family Nurse Partnership really remains the best one. How many are familiar with Family Nurse Partnership? This is a program for moms that are determined to be high risk, and if you look over the last decades and how what constitutes high risk has varied from study to study, but not that dramatically. Generally speaking, people who are either from neighborhoods or who identify a history that would put them at risk for their kids having some sort of abuse or problem in school. That's what I mean by at risk in this case. So moms who are at risk get paired with a nurse who has regular home visits and talks about what it's like to be a mom and answers questions and provides some education and support through and after pregnancy. And it has been consistently shown to reduce the rates of violence, of CPS reports, and show improved academic functions in the first 5 years of life. That's really cool. And interestingly, when people have tried to replicate it with cheaper clinicians, it hasn't worked. It only seems to work when you use nurses. And I think that's cool, and I love nurses, and I think that's great. I can't say I fully understand why. I have a theory, but it really does seem to only work with nurses. My theory, I don't know that it's really been studied, is that people's anxiety is often about what can go wrong medically. And having a clinician in your home provides sort of an authority that is more accepted than if you have like some of the attempts to replicate have used social workers, some have used people who were really college students that were just trained with a manual. So I think that the authority and wisdom and ability to answer medical questions is probably the difference, but that's my theory, I don't really know that. Anyway, why am I dwelling on this so much? Because I do think if we're going to invest as a community, and when I say invest, I mean time as well as money, we should probably really only use things that we know are evidence-based and are going to work, and fidelity to the models that things were initially tested under is really important. There's parenting training programs, and there's a variety that meet a threshold of evidence to have an impact on referrals to CPS, school performance, and a decrease in those externalizing behaviors I've talked about. I'm actually pretty agnostic about which one is best. If you have a community that'll pay for one, again, that meets the threshold of evidence-based, I'm supportive of it. The one we're using right now at University of Rochester has a very nice name that I'm not remembering right now, but has a three-word name about building skills of resiliency, and then after that it's called the 4 R's and 3 S's. And the reason we've picked that one is because there was a project from Columbia University that we could jump onto and some funding to support the analysis, but it's also something that health insurance will currently pay for. Whereas most parent training programs, health insurance doesn't pay for. So we picked one that at least this year, at least these couple of years, we can use within our healthcare system. Anything we can do to reduce and modulate the domestic violence in the home has an absolute effect on externalizing behaviors and on traumatic incidents impacting kids. Not necessarily direct abuse from their parent. Again, it's a risk factor for a variety of bad things. As we think about general themes, it's just really important to remember that we can identify and really support positive protective factors to foster resilience. And the themes across these programs are healthy attachment relationships with a caregiver, Usually studies are looking at moms, but it can be either gender parent, it can be both, and it can include non-parent healthy attachment figures. Ability to regulate emotions and behaviors. So some sort of training for kids to have a way to, this is what I do when I'm upset. You know, this is what, recognize their feelings and then have some sort of skills. And this is hard, and kids don't, you know, some kids don't like it and don't do it, but it's one of the important themes. And then supportive environmental systems, including faith-based communities. And I believe there's a few reasons about this, aside from my own personal beliefs. The idea of having a community of people with a positive development goal is a supportive environment for kids. There's also something to the predictability aspect. You know, that one of the themes of resiliency is people can tolerate a lot of horrible things if it happens predictably and consistently. And I'm not suggesting that let's all abuse kids consistently. That's not what I'm saying. But you know, having a predictable schedule, environment, you know what this adult's going to say about this behavior. That really does help, and that really does happen in churches. Education systems. Having a supportive education system, again, one of the important places where we can have a supportive environment. And then sometimes there's cultural beliefs or systems that either through narrative and talking or through actual direct interactions and getting together can again provide these supportive environments. And then there are cognitive factors, which we can't often control those, but kids who are motivated to learn and do something and then giving them the opportunity to do it is, again, one of the themes across the evidence-based programs to promote resiliency. Now, if that all seems too heady or vague, let me reduce it to things that in our YRBS study in 2017 seem to be really impactful. And it was these three things. There was a variety of questions trying to capture resiliency factors. And these three had the most impact. And I think they're really neat. You can think about, you actually don't have to be a doctor or clinician to address these things or do these things. How could you do this in your practice, but in your community, in your life? If kids answered yes to I matter to my community, if they answered yes to I have at least one non-parental adult who's a support in my life, or if they answered yes to I received encouragement at school, to any one of those or all of them, that had a modulating effect on the negative things that I was just talking about coming from the ACEs. And I'm going to show you that. So, to that question, I have at least one non-parental adult support in my life in terms of who said yes and who said no. Now, in terms of trying to assess the impact of feeling supported by people other than your parents, we can't analyze that without looking at the number of ACEs that they actually had, because the groups are a little different, right? But not that different. It's still, 27% who report having a non-parental adult support in their life said they had no ACEs, and 38% in the group who said yes. But, and that is significant, but it's still about a quarter have one. It's still either 15 versus 16% have two or more. I'm sorry, have two, and then similar numbers for 3 and 4 as well. So the groups are not that different, and yet, if we look at then again, people who answered no versus yes to the question that's on the left there, for substance use, for those who said no, it was 25% said that they, this is for people all in this graph, all have 2 or more ACEs. Okay, so we exclude the people with 0 and 1, and then look at who answers yes versus no to this question. And if you can't read it, no is on the left in each box, and yes is on the right. For those who said no, who had 2 or more ACEs, 25% said they came to school drunk or high in the last 12 months. And only 15% for those who said yes. Now, I'd love to say it was 75% and 0. It's not, but that is still a huge effect size. That is a huge impact. For suicide, have you ever had suicidal ideations? This isn't suicide attempt, but considering suicide. For those who said 2 or more ACEs, who answered no to the question of a supportive adult, other than their parent, 38% reported that they had contemplated suicide, and only 24% if they answered yes to that question. For the mental health, just feeling sad within the past 2 weeks or general emotional distress, it was 60% for 2 or more and 46% if you said no, and 46% if you said yes. That's really cool. This is not, our effect size for antidepressants is larger, but it's not that much larger. This is really cool. This is really cool stuff. I receive encouragement at school. Now, depending on what your guys' day-to-day life is, you may not be able to directly affect this, but even being active with school boards, making sure that your schools take this seriously, with the schools in the neighborhoods you live in, is something that I think is really important. This is when you interview kids and you try to think about what this means and what this question is about. This doesn't have to be a teacher, it doesn't have to be a principal, but it's the idea that there's someone that's part of a team at school rooting for you, encouraging you for success, right? Meeting you at the door, asking you how you're doing, knowing your name. Again, this is breaking down for those who said yes, I receive encouragement at school versus no. Here we see a bigger variation, right? In terms of the people who say they receive encouragement at school, they tend to report less ACEs than those who say no. There's a chicken and egg issue, right? And this is a survey. So people who have experienced more trauma might in fact be exposed to the same level of encouragement and not feel it as encouraging. So that is certainly possible, and that's a caution to over-interpreting or overvaluing this one. However, if we think of it as not just someone shaking their hand and saying, good job, buddy, or keep up the good work, but having a goal of actually knowing you have the kid feel encouraged, then I believe we can interpret this as useful and valid. And again, significant differences for substance use showing up drunk or high in the last 12 months. 21% who answered no, and only 12% for those who answer yes. For considering suicide, 32% for those who answer no, 22% for yes. And for general emotional distress, or depressed mood for 2 weeks, 56% who answered no, and 42% who answered yes. And this one, I matter to my community. Again, how do we establish that? Well, we could debate that and think about that. But if you get to the point where a kid says yes versus no, I matter to my community, we do see a difference in terms of how many ACEs they endorse. And we don't see the same effect on substance use. That's interesting. I don't know why. But we see a bigger effect on suicide. In fact, this is the greatest effect size on suicide. People haven't considered suicide. Whether a person feels like they matter to the community, a 20% difference for those who have 2 or more ACEs. And for the feeling sad for 2 weeks or more general emotional distress, it's 25% difference. So that's really cool. That is a huge, interestingly, I mean, it is striking to me that we see such a huge effect size for these two and not for the substance use disorders, but that is nevertheless what the data shows, and I think it's really neat and really cool. So how can we do that? How can you implement that in the life of the kids you work with, in your communities? Well, that's something to think about and something we can certainly talk about. I have a tool that I want to share with you guys, and we can email this out to everyone or post it on the website. This is also from CCSI and Monroe County Department of OMH and Department of Public Health, and it was supported by grants from Wilson Foundation and community partners. And this, the quote on there, in case it's too small to read, I believe we all have the capacity to become resilient, but our parents, siblings, extended family, and community can either give us resilience or reduce our resilience. I also believe that resilience is like a muscle. You can strengthen your resilience just as you strengthen a muscle. I think that's really an important point. And while the data I have about teenagers and my experiences working with kids, I believe this is actually true across the lifespan. I think when you have schools and you have Sunday schools and you have kids that are like used to being told what to do and where to go, it might be easier to implement this at a community level. But I really believe that particularly I matter to my community. I believe this continues to be profound and potent as a resiliency factor throughout life. And again, to this tool, I'm going to actually, it's in a PDF form. And what's neat about this, and why I'm showing you in PDF rather than cutting and pasting it or moving the slides, is it's 4 pages here if you were to print it, but I don't recommend you print it. I recommend you use electronic, because each of these is a link to a resource, to a website. So the first is ACEs Too High, which has a lot more about the research about the impact of ACEs and some of the work to address it that I was alluding to in the first part of my talk. ACEs Connection is, again, more resources about ACEs and people who are trying to address them in their community. The Center for Disease Control has a detailed review of that first survey study that I mentioned. And again, there's more. So this is, Paper Tigers is actually, if you'd like a video to see, a movie, even just for your own interest, about creating a trauma-informed school and trying to address adverse childhood experiences with kids who are all scoring 4 or more. Paper Tigers is a neat movie looking at that. And then, so that, the first page is generally about ACEs data. The second one is about resiliency, and specifically trying to foster resiliency in the community. And the Community Resilience Cookbook has a ton of different ideas. It's, you know, I don't think I have an active internet connection, but as you can see, it's got the little finger there. It does have the link embedded. This one's communityresiliencecookbook.org. But it has a lot of different things people are trying and doing. In terms of things that organizations can do, if you're part of an organization that wants to move toward being trauma informed, there's free resources to help do assessments and sort of trainings and things you can do to try to create a trauma-informed environment in the places we work. And then local resources in Monroe County. So the coordinating, I mentioned CCSI before, and they have a lot of information and an ability to consult with organizations about building trauma-informed care services. The Consortium on Trauma, Illness, and Grief in Schools is called TIG. How many of you have heard of that? Only one, okay, so 2. One's my wife. So TIG, and she's heard of it from me because I do part of the training for TIG. But TIG is actually a really cool thing in our county, and it's expanded out of Monroe County. What we've tried to do, and I say we because I've been part of the training, but it was not my idea and I don't want to try to take credit for it, was to create response teams embedded in schools to respond when major level traumas occur, right? So like a suicide of a student, or it could be a death of a student's parent or a student by any means, or a bad car accident, or the kind of things that would disrupt the school day and be majorly impactful. To create a team among the regular employees to come up with a consistent, appropriate, when possible, evidence-based approach to providing support to students, outreach to their families, and support to each other. So not only is it training for the school professionals who do it in the districts that do it, and most in Monroe County now have, but they'll also cover for each other, right? Because if you think about the community you live in, if a student were to kill themselves or try to kill themselves, the odds are it's going to affect a lot of the adults in the building too, right? And they may not be in the position to be the first responder, so to speak, emotionally. So if an incident happens in Child Eye, people from Gates and Brockport's TIG team come and will be the on-site support. It's a really neat group that has come together, and how each school is implemented it varies. One that I think is the most creative was actually to create a coaching position. It's not really a coaching position, but it can get paid like coaches get paid, to be the coordinator for it. Because most of the folks, they just added on as a new job responsibility to do this role. But we do a lot of education, and it's not only about response on the day an event happens, but about communicating effectively with parents and with mental health providers. So like say if a kid tries to kill themselves and is admitted to the hospital, or a kid has a catastrophic illness or an accident and they're in the medical hospital. And also when events happen, these post-vention, that might be a term some of you are familiar with or not, but you know, like in a lot of the post-vention literature is around suicide. What type of recognitions do you have for kids so that you don't unintentionally create a contagion situation? So lots of neat stuff that TIG does. There are some other agencies that we have links to here. Mount Hope Family Center has really done a lot to bring high quality evidence-based trauma-informed interventions to our community, working with foster care population as well as others. And there's more information there's a link to the site with more information about the YRBS as well. And again, I'm not reading every single thing, but that's, these are sort of the final points. What are the things that you can do now, whether you're a clinician or not? You can try to connect with youth in the neighborhood and community. Right? This idea of just being encouraging and supportive, it's really powerful. And we don't always get to know when it's happening, right? You know, we don't know if the things we're doing to be supportive are having a dramatic effect or not. But I hope that looking at the YRBS data and reflecting my own experience, you can get the sense that if you do it regularly across a group of lots of kids, it will help, it will make a difference. You can volunteer in a mentoring program. One of the things that the way we do the survey with YRBS isn't really able to capture, I don't think more questions would help, is, you know, what makes evidence-based or effective mentoring? And this is an area that I think we need more studies, but it is pretty clear that mentoring can provide the supportive adult, the encouragement, and it happens in Boy Scouts, it happens in churches, it happens with groups in our city like Pathways to Peace, connecting with youth and Big Brother programs, Big Sisters. So mentorship, I think, can be really powerful and important. Offering targeted feedback to youth you work with about strengths. This is something that you know, we don't always do, right? Human nature is to point out negatives rather than positives. But for kids who are struggling to, you know, find their place in the world, so to speak, and wondering whether or not they matter to the community, telling them what they do well can be very powerful. And there's totally, I don't have data or a slide to present about this, but there is a major mismatch in our community. You know, kids in that area that the term the Crescent neighborhoods is used, they get less eye contact handshakes and attaboys than kids in Pittsford and Brighton. And it just is. And that's, you know, it correlates to money, but that doesn't cost money, right? So I think that that is something that, you know, if we can really, it sounds so simple, right? It's hard to do at a community level. It sounds so simple, but I believe it can really have a big impact. And you can also try to understand when you see someone who's aggressive, who's difficult, you know, they're probably doing the best they can. And rather than have the first question or reaction be, what's wrong with you, or what's wrong with this person, the first question should probably be, what happened to you? What happened to this person? How can I understand this in the context of their life? And if you approach people that way, it's just easier to work with them and to sort of get through the difficult things we can face. Again, be a positive, consistent, caring adult. Make sure that youth know that you care about them. Share and apply what you learn in programs like this in your day-to-day work. I mentioned at the very beginning I do a lot of talks, and I know that some of them are almost like a summer camp experience where you go to this isolated environment, you learn some things that are inspiring, and then you go back home and it doesn't connect to your life, right? And so really try to think of, if any of this made any impression on you, try to bring something home and do it. Don't have this be just an isolated experience. All right, that's what I got for today. I really thank you for your attention. I have time for questions, and welcome whatever questions you have.
When they ask about, when the survey asks about support from an adult that's not a parent, if asked to name who that individual is, what do they say? Which are the most common?
So this is a survey that, in this case, there was like 1,700 respondents, and we're just looking through this. And that was a yes or no, but essentially a multiple choice survey, so we don't have that,
Okay.
information. I can conjecture, but it would be conjecture.
Yeah.
But I think the important point is, and they ask the question on purpose, is it doesn't specify,
Yeah.
right? And I think that's actually kind of cool. It doesn't have to be the teacher or the principal. It would be interesting to know who might be the most impactful or most frequent, but it doesn't specify.
Is there data on frequency of ACEs with how many parents there are in the home?
So it's sort of in the definition of how we ask. So if I tried to just answer in one word, I guess I would say not no or not exactly. Because if you start with one parent and you have stable one parent throughout your life, you would answer no to the questions the way they're framed. But if you lose a parent, if your parents start together, even if it's only a narrative, right? Like even if you don't remember that your parents were together for the first 6 months of your life, but it's the narrative in your household, then you would answer yes about a loss. So it doesn't capture it exactly the way you're asking. But I actually think there's an important piece of information in there, and it goes back to what I said about consistency and predictability. In fact, predictable, consistent single-parent households are not associated with, by itself, being a risk factor for traumas or for other problems. It's just that having only one adult in the house runs with all these other risk factors, and it's more likely, or it's harder to be as consistent. And again, we can just think about this intuitively, human nature. It's harder for one person to do it all than two, right? But by itself, doesn't equal an ACE or risk factor. But a loss, a separation, particularly if it happens in the context of violence or death, or incarceration, are significant risks. Yes?
Yeah. One of the things we did in my clinic was one of the PAs and I went to East High School.
Oh, cool.
And so we went in there and we talked to the nurse and the guidance office, and we said, we're a clinic nearby. If you have any kids that want to learn more about health careers, come and be mentored, we open ourselves up to that. And the Hillside staff were really open to it.
Nice.
They just jumped right on, and so we've had 5 kids that have come through. They came about 6 or 7 times.
Oh, it's fantastic.
We're going to repeat it, so if anybody's interested in connecting with Hillside or talking more about that, we're about to start a second go-around with it.
I think that's
Instantly, we're just like, that's amazing. Like,
Yeah.
we have kids that want to do health, right from the city, and so I would love it to catch on and for more clinics to take teenagers in there.
I think that's fantastic. We have a program in our Department of Psychiatry where we try to do that as well, where we have high school students. It's actually open to anywhere across the region, but we're specifically wanting to encourage folks from these high-risk neighborhoods to have some sort of positive experience. And I gotta tell you, actually, if any of you've done this, you may be able to resonate with this. I have people shadow me all the time, right? And most of them are medical students, which is not the same as being a high school student. But even among high school students, even among college students who are more affluent, the single day or half day with me is less impactful. Because they have opportunities, they have more of those experiences than for folks at East High or in many of the city school districts. So not only to do these kind of programs, but if you can find it not only in your heart, but logistically feasible to specifically like partnering with East High or partnering with another school in the city, I think that's great. Or it might be using an agency like Hillside to help identify the youth. That's fantastic. David?
You mentioned the family nurse visitation program for
Yes.
single parent
Family Nurse Partnership, yes.
partnership. Okay. Do you know whether all the nurses who did visitations were women or were some of them women?
Oh, that's a good question. I bet that's, I don't know. Yeah, I don't know. I'm gonna find out, because I'm curious now, because again, I really am curious why it only works with nurses. Again, I have my theory and I love nurses and I'm glad, but I don't know, and I wondered, maybe gender is an effect. Yes?
So is there something we could do maybe for like adults who've maybe gone through these experiences?
Yeah, so I know the most of the work I do is with kids and teens. The comment I made, I actually believe that these principles, particularly if you use the metaphor of like exercise, right, and building your resiliency muscles, I think the principles are the same. It just may not be as intuitive as to how to implement. Right? So I think I'm actually having an association right now I'm just going to share. In some of the violence work I've done, there was a group that I believe Wegmans was sponsoring it. I can't remember who was leading it right now, but they had this byline that nothing stops a bullet like a job, and that for adults who are at risk or stuck in kind of the sequelae of chronic violence, so it may not be that you can go to a school or go to a place. It may be that you have to create a purposeful activity, right? And it's easy to think about that in terms of employment, but it might be volunteering. It might not be employment, but a purposeful activity which can then give a sense of value to the community, have interactions with other supportive adults in their lives. So that's how I think about that, and that's what I would look to do. Yes?
Just a lot of substance abuse treatment outpatient programs have a lot of programs for adults.
Yes.
They have this groups, survivor groups, just a lot of different things which helps them to heal and connect with other people.
Absolutely, and I don't think I said this at all explicitly. I think if we identify distress and we can connect people with formal mental health services or groups and healing activities, we absolutely should. Absolutely should. And at the same time, I really think resiliency promotion is about doing something. And so I think that having groups can be essential to helping people get through and heal, right? And just, but even if we had a surgery or an injury after a car accident, we don't just do our medical interventions to help someone heal, right? We don't just set them in the environment. They also have to do physical therapy. So I think that's right. I think there's many, if people are actually suffering with substance use disorder or addiction, then connecting them with one of the programs that offers all these supports, absolutely, right on. But even if not, the models of the types of groups and the types of activities, I am not familiar enough with Total Freedom to speak to what you do, but just from what I heard Chris say, you talked about employment, right? You talked about purpose, and you talked about the long-term with transitions. There's a residential component, then there's a next step to build your own life, and I assume that includes progressive levels of, I'll say the word independence, I don't know if that's the right term exactly.
Absolutely, and to touch on that, I just wanted to throw a statistic out there. There's 22% of the people that sign up for the program complete the 9 months. After that, 78% of them are doing well. But statistically, the ones that use the 12-month follow-up, that do the transition and follow up for the 12 months, 98% are still doing well. So you're pretty much guaranteed, if you're going into the programs like Total Freedom, in Total Freedom, someone, if they go through the 21 months, there's a 98% chance of success. And the reason being is because we focus so much time on getting to the root of this ACE. We focus on really digging down deep into what's causing all of this and get the freedom there, because that's where the total freedom comes.
Fantastic. Dave?
So I bet you there are a few people in here who have relatives who are adults who, I know I have a few who could benefit from understanding a little bit more about ACEs and how it might be impacting them. Are you aware of any books that might be good gifts to them?
Yes. Okay, great. I believe there's one in the resource here. So, The Deepest Well, Healing the Long-Term Effects of Childhood Adversity. Gives some of the background in ACEs, and then it's, as the name says, it's largely about healing. And you know, it seems like I'm being overly focused on the action, doing something. Learning about this has been somewhat transformative for me, and I've also seen people who focus on their adversity and their suffering and they get stuck in it. So I just want to encourage, and I hope I'm being clear, I'm a mental health provider. I do general medical care. I made my, the last part of my career about expanding access to traditional mental health services. But I'm struck more and more about you have to also have this action component of doing something. And if we think about our, faith upbringing, right? Faith without actions, right? It's not, if if we're not doing something, we don't really see the benefits. Yes?
I wanted to share something. I taught a course in mental health in Burundi for 6 different years, and one of their in medical school. So one of the projects I had to do was write a couple-page essay on post-traumatic stress, and they were just second-year students on a 7-year program, so they hadn't had any clinical stuff. So they had to interview a friend, a family, or they could write about themselves and what the symptoms were, and then what kind of healing they got, if any, and what happened. And so it was a number of them wrote about themselves and the genocide. And it was really, I almost was crying as I read some of the accounts. They saw their parents killed in front of them, or one was abducted as a child soldier. But all of these people had recovered enough to go to medical school. But they had no psychiatric, and they have a number of programs there. But in the church, what they shared about the church was just incredible, and mentoring. And some of them turned to alcoholism. One of them, at age 16, he got involved with a pastor, and just the whole idea of forgiveness, the whole idea. But it was a very long process. They would all say it was not like they just went to church and they immediately were delivered. It was in the idea of forgiveness, forgiving those that had harmed them and so on. And just a very long, hard process, but they really work in community. And I thought I should share that. Because even in our own churches, if we can have community, but we're just having difficulty in our society developing healing communities. So,
in hearing you talk, it also strikes me, I think I've seen, and if I'm counting experiences clinically, it's actually more with parents who expect, whether it's a secular intervention or a moment of being saved, they expect everything to be better tomorrow.
yeah.
Right? And I think that's part of what I was thinking of as I heard you explaining that, and the long course that these youth and the young adults went through. It doesn't happen like that, right? It's a long process.
But we can give them hope, too.
Yes, yes.
The medical students or other people have done this. We've seen these people.
Yes. Yeah, powerful examples, and especially real people. Actually, Susan's not here right now, but she was the lead in this video. I don't know how many of you've seen the front row or the follow-up, Creating Hope. The whole idea of creating hope is role models of resiliency. It's people who, it's got a little bit about self-regulation and kind of getting through, but it also has stories and narratives of people who are, on the other side of having suffered significantly often in childhood, and got through. And having real life role models is really powerful, and probably more powerful than any words we can say. So I think that's really great. Yes?
Yeah, I just wanted to share, I'm a mental health provider. I'm in private practice, and I also do work for 441 Ministries, which is evolving, and I've been there about 5 years, and it's a slow growth, but they're reaching out to high-risk families and kids in the neighborhood. And my first initial response was, yes, God is here, so that is good. But what these kids who are coming in, some of them were 4 years old, walking down to the kids' ministry in their pajamas, parents not knowing they were out of the house. I'm thinking, how much of an impact can we really have when they're going home to every risk factor, some checked off on the boxes? And most recently in my private practice, I had a family that took on a sibling group. And I do my trauma-informed assessment, and I'm looking at these kids, and the family brought them in not because of very elevated risk factors going on, but just they knew these kids had a rough background. They handed me the CPS documents of them getting out of the home and what transpired in their lives, and it was just, I've read a lot of those. This one was like a horror. It really was. And these kids were okay, and the parents were thinking, we're waiting for the explosion. What's going on here? What is your assessment? So of course I went through the trauma-informed aspect, and every possible thing had occurred with these kids. And I'm looking for that protective factor, that connection. And we couldn't come up with anything. And then one of the parents, like the fourth visit, said, they were involved in this thing in their neighborhood. And it was the 441 ministry. And then I started questioning the kids. And they admired and looked up to the people in their lives, the only adults they had, who they went down for food. Then there was also a church that was also involved. The church has only been there a few years, and they had people that cared about them. And they still talked about the people, not knowing that I recognized the kids from years ago. She was the 4-year-old that walked out in her pajamas, at 8 o'clock in the morning. So I just know it has an impact, and God had to let me see that piece of it. And these kids definitely have risk factors, and the parents are not believers, the parents who adopted them. They're very brave people to take this sibling group on. But I'm still trying to show them, this was a protective factor. There wasn't a grandparent. There was nobody in this. They had every form of abuse possible. So those connections, in any way you can make them, are so important.
Oh,
Yeah.
tremendously.
Yeah, it's just so,
Wonderful
yeah.
story. Wow.
Yeah.
Absolutely. And to the point of the exercise with writing about PTSD, I think that another thing people can do or suggest is journaling. Journaling won't help everyone, and there's a risk of journaling turning into ruminating, which doesn't help. Ruminating is bad. What you want to see in journaling is reprocessing. And if it's going to help, you probably see the difference in a few days. So it's also the kind of thing where if you're going to encourage patients or you're going to encourage people to journal, and they said, I've been writing this journal for 2 weeks and I haven't learned anything, I don't feel any different. Next thing I say is, okay, don't do that anymore. And then we do something else. But I mean, it's, compared to other interventions we might do, it's not going to cause harm. Again, unless it gets people ruminating more, but even that, most people stop if that's what happens. Narrative, I wonder with the situation you described with those siblings, having a narrative which those siblings could reinforce with each other, even if there's not another adult doing that consciously or unconsciously, they could be reinforcing a narrative of resilience